Hi, everyone. Thank you so much for joining us today for this HepVu webinar. We will get started momentarily, just going to let folks join the Zoom, and then we will go ahead and kick things off.
Good morning, good afternoon. This is Dr. Ron Valdesari. I'm the co-chair of HepVu, and I am delighted to welcome all of you to a special webinar presented by HepVu on the impact of the COVID-19 pandemic on viral hepatitis prevention, control, and elimination efforts in the United States. Next slide, please. We hope during the course of this webinar to accomplish three major objectives. We certainly want to describe the impact of the COVID-19 pandemic on viral hepatitis prevention and control efforts in the US, including ongoing elimination plans. We'd like to identify strategies, including advocacy, to promote continued support for viral hepatitis prevention, control, and elimination during this period and after this period of the pandemic. And finally, we'd like to characterize potential program and policy actions that could serve to integrate viral hepatitis prevention, control, and elimination activities into the ongoing response to the COVID-19 pandemic. Next slide, please. We have an outstanding panel put together for you. We're going to be hearing from Dr. Alexander Billioux, who is the Assistant Secretary for Health in the state of Louisiana. Then we're going to hear from Boatemaa Ntiri-Reid, who is the Director of Hepatitis at the National Alliance of State and Territorial AIDS Directors. And finally, from Lauren Canary, who is the director of the National Viral Hepatitis Roundtable. Each of our three presenters will make brief remarks touching on some aspect of the objectives that I presented. And concluding all three panelist presentations, we will open it up for Q&A. So in order to ask a question, the audience needs to type it into the Q&A box that you see at the bottom of your screen. And once again, we will take those questions after all three panelists have concluded their presentations. Next slide, please. I want to begin by welcoming Dr. Alexander Billioux, and we'll ask Alex to share with us his perspective from the state of Louisiana. Alex?
Thanks, Ron, and thanks everybody for joining. It's a pleasure to be able to talk about the work that we have going on in Louisiana. When Ron and Chelsea first reached out with a HepVu webinar opportunity, I was really excited to talk about something that wasn't COVID. And then when I got a chance to talk with them more about the nature of today's talk, I figured at least it's COVID plus. I'll take that. I'm really excited to be talking about something that had been a major focus of our work here in Louisiana, really pre-COVID, and certainly has been in our thoughts. So I think actually the topic is a really great one. And you know, happy to share what we're doing, eager to learn from others as well, especially through questions and answers, and getting to hear from folks like Boatemaa and Lauren as real leaders here. So next slide. Some people, an audience of HepVu webinar attendees don't need to be convinced that hepatitis C is a huge problem in the country. And certainly, one of our most challenging infectious diseases, really, until we were wrestling with the COVID pandemic. Really high rates of death nationally, traditionally the deadliest infectious disease in the United States, and was getting worse. And certainly in Louisiana, this is data showing you trends in chronic hepatitis C diagnoses between 2009 and 2018. And this mirrors a lot of what's being seen across the country, partially fueled by an increase in substance use disorder, especially opiate use disorder, at about the midpoint of the 2010s, 2014, 2015 really kicking off for us, showing a growing hepatitis C challenge in the state. Next slide. In Louisiana, like in many places, not only was it that we were seeing more hepatitis C, but we were seeing a new group of individuals really living with hepatitis C infection, with chronic hepatitis C infection. So what we're depicting here is some data from Louisiana in these 4 quadrants. For those of you who don't have a big enough screen, upper left is 2006, then upper right 2010, lower left 2014, lower right 2018. This is histogram just showing the age and number of individuals with chronic hepatitis C diagnoses at that age of diagnosis. And what you can see as we progress from 2006 through the 2018 is the development of this second hump, this bimodal distribution really becoming quite prominent, where that initial group in 2006 that was largely the baby boom generation, who we've traditionally been reaching out to and trying to engage for treatment and cure, was now being joined by a new younger generation of users, or rather of chronic hepatitis C infected individuals, largely users of injection drugs in that new number. And so with that new group of individuals coming online, we also had just overall growing numbers of people. And this really presents a very challenging picture for the state, for our citizens, because we know that this younger group will go on in decades to develop the consequences of chronic hepatitis C infection if we don't do anything to treat them. So we felt a real urgency in the state with the opportunity to cure hepatitis C at rates of 95% plus, to get access to medications into individuals' hands, and really try to achieve the WHO goals of elimination. Next slide. So we've talked a lot in a bunch of different areas about our goal of eliminating hepatitis C. For the purpose of this talk, I won't go into my long-winded speech about the path that led us to our goal to eliminate, and really the subscription model that we have that enables it. But I will just emphasize that this has been a real driving force, not just within our STD HIV hepatitis C program, but really the Office of Public Health and the Department of Health in Louisiana in general, as a moonshot opportunity to really focus our efforts and achieve a very, or really target achieving a very specific goal like the elimination of hepatitis C, but understanding that in order to do that, achieve that goal, we would have to tackle all sorts of challenges that we face across public health. You know, the coordination of our health systems, the interaction between public health and healthcare, the way we share information, the way we engage communities, the way communities really drive our program development, and not just having it be a one-way street. All of that has really driven, or was a part of the planning and the decision to aim to eliminate hepatitis C by 2024. And again, our goal mirrors, I should say, the WHO goal of treating 80% of Louisianans living with hepatitis C by 2024, so 5 years before the WHO goal. We'll have, I'll touch on briefly how maybe COVID-19 changes that timeline a bit. Next slide. Just to note that in order to do that, we were really having to layer on not just access to drug, which was certainly what I think got the most attention nationally through a subscription model, giving us unlimited, unrestricted access to the generic form of Epclusa through an arrangement that we have with Segwa Therapeutics, a subsidiary of Gilead, both in our Medicaid and corrections populations, but then understanding there's all of these other barriers that we would need to address systematically to ensure that we were engaging the public, activating the public for screening, for testing, getting the public that was then aware of their status linked into care, making sure that we are supporting the healthcare infrastructure with information about people who should be coming to them, and then pulling information back from them about how people were progressing through their treatment courses. In a state like Louisiana, where we had traditionally limited access to treatment to initially specialists and had a number of utilization management restrictions and prior authorizations that really sort of disincentivized providers from engaging in hepatitis C care, we needed to unwork all of that at the same time that we also expanded provider capacity and trained providers to treat hepatitis C, and launched a large statewide webinar series, really trying to use the Project Echo format to get people across the state ready to treat. And then implementing good public health, harm reduction, complementary strategies as we tried to expand this statewide. And so in July of 2015, July 15th of 2019, we launched our hepatitis C model. We can go to the next slide, which is my last slide. And what this really depicts is sort of what was the course of hepatitis C treatment. And this is through Medicaid and corrections, a number of people who are being treated shown on the y-axis, and then time being depicted on the x-axis. And what you can see is that, on average, we were, starting fewer than 100 people on treatment every quarter across the time preceding July 15th, when we actually started our hepatitis C model. June 15th. When we started our subscription model, giving access to unrestricted access to drugs, eliminating all prior authorization requirements, all sobriety requirements, expanded provider trainings, all in the run-up to that, that change in access to drug, you see a really dramatic increase in individuals being started on hepatitis C, upwards of 4 to 5 times what we had been previously treated. In the first 75 days of the subscription model being live and the elimination program being live in 2019, we treated as many people as we had in the entire previous previous year up to that point. And then going past that, we knew that we were seeing an initial peak of folks that were really the bottleneck, the people who were probably in line to be treated, but just waiting because of prior authorization requirements. And so you see that initial peak, and then a little bit of a downturn that we figured was now, really needing to rely more on people who were coming in through screening with our multimedia outreach to folks. But then we also had some further reductions in our rate of testing that were driven by issues that we were having within the state. So we had a pretty large cyber attack in November that limited the operations of the state, limited operations of Medicaid to some extent. And then we had some holidays with Thanksgiving and Christmas and other winter holidays in December. So we saw, a slump in our level of treatment, and we were heartened to see that bounced back in January as people got back from the holidays and back to treatment. Right around the time that then COVID-19, the COVID-19 epidemic really took off at the beginning of March. And what you see is a precipitous decline in people starting hepatitis C treatment as a result of clinics shutting down. I mean, largely our federally qualified health centers or community health centers across the state and our major health systems that were able to do elective outpatient care were driving screenings, connection to care, and prescription of the authorized generic of Epclusa. And so as we restricted that as a result of COVID-19, we see a precipitous decline. And so going forward, certainly we've been, for a period of time in Louisiana, impacted by our very high rate of COVID-19 cases, now have been able to really bend that curve, and most of our state below a relative reproduction rate of 1, starting to see consistent declines in cases and hospitalizations. We have been able to move through phase 1, and now on Friday of this week, we'll be moving into phase 2 of our Restarting a Resilient Louisiana roadmap, And part of that includes re-engaging elective and outpatient care fully. We've seen some reluctance for folks to re-engage in care, concerns, no doubt, about individuals' risk of acquiring COVID-19 as a result of attending clinic. But we really are doing our best to try to eliminate that concern and relaunch engagement in care. And so going forward, I think we're going to have to look at how this period of time dealing with COVID-19 impacts downstream relaunch of hepatitis C treatment. And again, we are still dedicated to, over the next 5 years, eliminating hepatitis C. We can talk maybe in the Q&A a little bit about how comfort and policy changes with telemedicine can help us even further reach into communities and break down barriers for individuals living with hepatitis C to achieve cure. But it's really going to take leveraging this moment and the health equity discussions that we've had around COVID-19 to achieve that goal.
Thank you, Alex. We'll look forward to the Q&A to get into some of these details, some of these issues in more detail. Now we're going to hear, we heard from a state level perspective. Now we're going to hear from a national level perspective from Boatemaa Ntiri-Reid, who's going to share with us some really up to the minute information about the impact of the pandemic on ongoing viral hepatitis program activities. Boatemaa?
Hello, Ron, I just want to do a quick check and make sure you can hear me. Can you give me a thumbs up? All right, thank you. Before I get started today, I just wanted to take a brief moment to acknowledge the unrest that's happening in our nation right now and the pain and suffering, both historical and current, that inform it. I also want to take a moment to acknowledge the devastating impact of COVID-19 on programs, of course, which we'll talk about in just a moment, but also on individuals, on communities, on many of you who are listening today, including those of you who may have had it or who may have lost a family member to it. And with that, I do want to just take a very brief moment of silence to just kind of reflect and acknowledge. Thank you. So with that, my name is Boatemaa Ntiri-Reid. As Ron noted, I am the Director of Hepatitis at NASTAD, and NASTAD is a Washington, D.C. based nonprofit where we focus on supporting health department programs that are specifically viral hepatitis, HIV, and harm reduction health department programs. Next slide, please. Our mission and our vision at NASTAD, our mission is to end the intersecting epidemics of HIV, viral hepatitis, and related conditions. And our big vision with that is for us to see a world free of HIV and viral hepatitis. So of course, when we have a global pandemic strike, our first concern is for people as a whole, but also in terms of doing our due diligence and the work that we've committed to in terms of supporting health department programs. Of course, we were thinking about how it was going to impact viral hepatitis programs specifically. Next slide, please. So what we wanted to do was to very specifically assess COVID-19's programmatic impact on viral hepatitis as well as HIV programs. I can tell you anecdotally, when this pandemic first started, at NASTAD, of course, we are a technical assistance and capacity support provider. And so we send a lot of resources, a lot of emails to our health department colleagues. We often get notices that somebody is out of the office working on a number of different issues. But what was very noticeable from the outset was that when we would send our emails out to our hepatitis colleagues, we would get 50+ emails letting us know that folks were out of the office because they had been detailed to COVID. I mentioned that just to say how we first recognized the significant impact that it had had. So next slide, please. To get a better understanding of exactly what was happening in health department programs, we developed requests for information. The request for information was disseminated at the end of April and collected through the beginning of May. we designed the request for information and not an extensive survey, a request for information to be short and comprehensive with the goal of being able to obtain this information while recognizing the competing demands that our health department colleagues were faced with. So we disseminated the request for information to viral hepatitis staff, as well as staff of Ryan White HIV/AIDS program, Part B, and AIDS drug assistance program staff, as well as HIV prevention staff, all within health departments. And in terms of responses, we received 49 responses from HIV prevention programs, 45 from Ryan White Part B and AIDS drug assistance programs, and 55 from 52 unique jurisdictions from hepatitis staff. This included viral hepatitis coordinators, surveillance staff, leadership, and others. So some of the key themes that we immediately saw upon reviewing or analyzing the results of our request for information was that hepatitis and HIV capacity had been significantly impacted across all programs as a number of staff had been detailed to COVID-19. Also, programs were struggling to continue to safely provide the services that they have typically provided in the past and had currently implemented. But on the flip side, we're seeing that a lot of folks are looking at innovative ways to be able to reestablish services or continue services during the pandemic. Additionally, we saw that programs are beginning to integrate COVID-19 activities into their hepatitis and HIV activities. And one very difficult issue that we see folks are anticipating is that there might be a budget impact. And I'll touch on that a little bit further in just a moment. Next slide, please. Thank you. So I'm actually going to start on the right side of this slide, looking at a snapshot of the RFI results. One of the questions that we asked in the request for information was, what do you anticipate the biggest impacts of COVID-19 would be on your hepatitis programming? And the top two that we saw were that 93% of viral hepatitis respondents anticipated that there would be a reduction in their outreach, education, testing, and linkage services. Respondents also shared that this was really going to devastate some of the momentum and traction that they had gained, especially in high impact settings like syringe service programs, many of which have not survived this pandemic to date. Additionally, 80% of respondents anticipated that detailing of health department staff to COVID-19 response would decrease their program capacity. And when we asked in a free text section about particular areas of concern, 1/3 of our hepatitis respondents shared that half or more of their staff had been detailed to COVID. One jurisdiction in particular described how everyone from their leadership through their student interns had been detailed. Additionally, we learned that 70% of viral hepatitis programs need more funding. They need more funding for prevention and surveillance. And this was not something that we were unaware of going into the RFI, but it was something that we definitely wanted to make sure to check in on as we asked respondents to respond to the RFI. Next slide, please. So I want us to keep in our minds that 70% that said that they needed additional funds. One of the other questions that we asked was whether or not the programs receive any state general funds to support their program activities. For the hepatitis respondents, only 40% of hepatitis programs responded saying that they receive state general funds, and the amount of those funds ranged significantly from $25,000 to $1.4 million, though I will say that the $1.4 million was a bit of an anomaly compared with the other levels of funding that were noted. Now, what is particularly concerning about this is that, as I previously noted, there are concerns about anticipated shortfalls with state budgets as a result of resources that have been redirected to COVID-19 response. That, in addition to the fact that viral hepatitis prevention programs in terms of federal funding, and which the vast majority of viral hepatitis prevention programs, that's how they function, off of those federal funds, receive on average about $114,000 for those prevention programs. And for the 14 jurisdictions that receive surveillance funding, they receive about $200,000. Now, this is not including supplements as additional federal funds become available. But when we're looking at the fiscal impact of COVID-19 on viral hepatitis programs, it has the potential to devastate programs that were already facing very limited funding. So with that, I just wanted to share my contact information, and I look forward to being able to speak a little bit more about how these issues are impacting programs.
Thank you so much, Boatemaa, for sharing those sobering numbers with us. Next, we're going to hear from Lauren Canary, who's going to share with us some of the more policy and advocacy related dimensions of the impact of the COVID-19 pandemic on viral hepatitis activities in the US. So let's turn it over to Lauren.
Thanks so much, and thanks for the opportunity to be here. And Boatemaa, I appreciate your comment and call for solidarity amid these times. I think more than ever, we need to be thinking about health equity in our work, and NVHR stands in solidarity with those who are marching in the streets for equality. So I look forward to addressing what we're seeing at the national level and from our advocates in regards to the intersection of COVID-19 and viral hepatitis. Next slide. There's a lot of things that we've heard about from our membership, and some of this, Boatemaa already covered, but certainly outreach activities seem to be taking a big hit. Folks don't exactly know how to do those safely, and they've been deprioritized given the impending threat of COVID-19. So a lot of the work that's done in the community and reaching folks at risk of viral hepatitis A, B, and C is done with health fairs, outreach, testing at syringe services programs, and a lot of those activities have been halted. So we're seeing lower rates of vaccination and testing, which is of course concerning for our prevention efforts, as these are sort of the cornerstone of our prevention efforts for viral hepatitis nationally. Unfortunately, a lot of syringe services programs are scaling back some of the work. I know we'll discuss this later on this month on another HepVu webinar, but a lot of programs weren't getting the same support as for example, health department outreach staff. Even though they may be on the streets and serving folks and even testing for COVID, we're not seeing PPE necessarily going to syringe services programs. So a lot of them have just out of necessity had to scale back. We're seeing pulling back on our hepatitis A outbreak response. The hepatitis A outbreaks have been widespread throughout the US starting in 2016. We had done a great job at batting this back around last fall to the winter, and we've started to see a resurgence of hepatitis A in some communities where staff who'd been detailed to the outbreak response had to then be moved to work on COVID. So Seattle most recently, we saw an uptick in cases, and we definitely need to keep an eye on that. And as Boatemaa reviewed, a lot of the viral hepatitis programs just really are limited in what they can be doing. Next. So I think as we think about downstream what the impacts are going to be, are that we're going to see fewer cases being identified and certainly fewer cases being reported. And we're going to need to take account of that and ensure that we don't make presumptions about our progress in eliminating the disease if we see a downturn next year, but rather try to do what we can to make up for this lack of detection. And one question is, with the lower rates of vaccination and testing and the scaling back of certain services programs, are we going to have increased transmission? We would logically say probably yes, but on the other hand, we also know with folks staying at home that networks, particularly among those who are injecting drugs, may be smaller than they would be otherwise. So we'll have to see kind of what happens down the line with the impacts of stay-at-home orders in concert with limited prevention tactics. Next. We've also heard, at least anecdotally, from our provider and patient advocates about limitations in clinical care specific to viral hepatitis. We've certainly heard from specialists in various jurisdictions that they're just frankly overwhelmed with the COVID-19 response and have no time for anything else. In particular, our infectious disease specialists, who are often called upon to address viral hepatitis. They've been detailed to COVID-19, and some are serving in the hospitals, some are serving in leadership positions with their health department to help with the response. But certainly, treatment initiation for hepatitis B and C has taken a back seat. And this is in concert with some guidance that's been going on to clinicians to hold off on that, which we have concerns about, of course, on behalf of our patient advocates. We've also heard that lab work and liver staging has been difficult for some folks to access, that some of the outpatient facilities that might normally do this may be limiting their hours or limiting the services that they do provide. Even lab work has been limited. We heard from a provider who wanted to do hepatitis C and B viral blood draws. They'd ordered PPE, but it was intercepted by the federal government to be used for COVID-19. So we're hearing, again, anecdotally about some of these impacts, and it's geographically limited. We're also hearing from folks in other jurisdictions where they're moving on with the treatment, they're doing lab work. So this seems incredibly variable, and we look forward to trying to quantify this. We've also heard from our patients that there's a shift in how they're thinking about treatment and making decisions about going to clinical appointments, refilling their prescriptions, and leaving the house can pose a risk. We know those with chronic liver disease are at greater risk of complications from COVID-19 and even mortality from COVID-19. So for patients, pursuing the viral hepatitis care just may not be the same priority that it would be otherwise. And then, of course, we've seen that some of the provider education activities are limited. In particular, things like ECHO, we've had to see a big shift towards COVID-19 management, rightfully. But this may have an impact downstream on trying to scale up our provider capacity, especially at a time when we're going to be implementing hepatitis C screening universally. It would be a great time for us to be training up our mid-level and primary care providers. But unfortunately, some of those activities have been halted. Next. So again, downstream, thinking about what we might see throughout this year and next year is that, a lot of folks are going to probably have limited progression along the continuum of care. Even, once diagnosed, we may see that bar drop off for the number who have been treated, or those who have an antibody test, we may see drop off in those who have had an RNA test for Hep C, for example. And our availability to kind of scale up limiter providers may be limited. Next. But it's not all bad. I've been trying to look for silver linings amid COVID-19, and we certainly are seeing rapid progress in some areas. And in particular, I think that we are shining a light on racial and ethnic disparities in access to care that have underlied our healthcare system for a long time. And they certainly underlie viral hepatitis outcomes. But COVID-19 is presenting the US with this really acute picture of the impact of COVID-19 and other diseases on communities of color. Next. And certainly give us an opportunity to support communities that are disproportionately impacted by both COVID-19 and viral hepatitis. So I have here for 2017, this is mortality data of hepatitis B and C deaths. These are all preventable. If we look at a breakdown by race and ethnicity, we do see that communities of color are disproportionately impacted. They are not getting the same access to care and to curative therapy. And the results are dire and they are fatal. And I think our discussions around COVID-19 in communities of color and the discussions we're having right now around race and systemic racism will be really important to continue in light of viral hepatitis, because we obviously haven't done enough to address the impact of this on all these unnecessary deaths that we're seeing. Next. So some other opportunities we have that have been presented by COVID are really to speed up our innovation in the field. And Next Distro was doing syringe services programming by mail for some years, and they've been helping other syringe services programs scale up their mail-based services, which is great. It'll really decentralize harm reduction access, which is fantastic. We're also seeing massive uptake in telemedicine. Progress in this level of uptake may have taken a decade, and we're seeing this in the course of months. Every clinic, every provider has had to think about how to adopt telemedicine into their practice, which again could help decentralize care and bring access to those that may live in medically underserved areas, both in rural and urban communities. The importance of mobile outreach is of course more important than ever, and I think we're seeing more mobile outreach being done amid COVID for safety purposes. And of course, virtual education. Next. Of course, we're seeing a lot of investment in the CDC and in our public health response. I won't read through all these, but basically we're seeing a lot of investment in a public health infrastructure that's going to support viral hepatitis long term. It may not be support directly to viral hepatitis programs right now, but we are seeing investment in things like surveillance systems, contact tracing staff, innovation in novel testing methods, and certainly investment in our interoperability of some of our EMR systems and vaccination registries. Next. So we're going to be putting out a survey later this week to quantify the impacts on the community. So make sure you're signed up for our newsletter. We're doing this in partnership with NASTAD and HepVu and some other national partners to really hear from folks on the ground what they're seeing in different communities so that we can do better as we're advocating on the Hill, as we're advocating with federal agencies to make sure our communities are served appropriately. So thank you so much for the opportunity to be here and look forward to hearing from folks.
Thank you, Lauren. We appreciate your comments. Can I have the next slide, please? I wanted to remind you, Lauren mentioned this, that next week, HepVu will be, or actually on June 11th, HepVu will conduct another webinar, this one specifically on the impact of the COVID-19 pandemic on harm reduction services in the United States. And you can see that we have a great lineup of speakers: Tyler Bartholomew, Don Desjardins, Dan Raymond. So I hope that you'll share this information with your colleagues. Next slide. Next slide. Great. Just for those of you who don't know about HepVu, by all means visit the website. You can see the information here. Next slide. And we do have some questions that I will be moderating. I want to remind the audience that if you have a question to ask, type it into the Q&A box. We have 3 questions. They're all from the same person. So I'm going to take some liberty here in how I moderate. I want to start with the question related to the impact of COVID-19 on the U.S. progress when it comes to hepatitis elimination. Now, clearly this is a bit of a crystal ball kind of question, and let me add a little twist to it. And I'm going to ask each of the panelists to respond, but if we want to keep hepatitis elimination in the forefront and keep it going, what kind of specific advocacy and messaging might we have to do? And I'll begin with Alex. And again, keep your comments brief because we want to hear from everyone. Alex, come off mute and share with us your thoughts.
Thanks. And could you rephrase that again one time?
Basically, we all support, obviously all of us on this webinar support viral hepatitis elimination. What do we need to do to keep that fire going? Because we've heard that there are a lot of challenges being made because of the competing priorities of COVID-19. So what do you think we need to do, Alex?
I think Boatemaa and Lauren hit on many of them. I think it's about seeing this challenging time as a potential opportunity to highlight the importance of public health and taking care of the public's health, and really integrating the activities that we're doing to address COVID-19 with activities that advance hepatitis C elimination. So, for instance, in Louisiana, we know that one of the key steps for us getting people into cure is identifying their status. About 50% of our population may be chronically infected and unaware. We also know that there's going to be a great deal of interest, and already is a great deal of interest in many of our jurisdictions, in serology testing for COVID-19 to understand what the public level of seroconversion is. I think leveraging those opportunities such that you're never wasting blood. If people are coming to get their blood tested, talking about the opportunity to also have their hepatitis C status known, counseling, that's an opportunity for counseling them about that. And then more broadly, I mean, we shared pretty early on in our epidemic to the issues about equity and really the moment that we are in right now of crisis as a nation, that we see a disproportionate level of death and burden of COVID-19 amongst our African-American population in Louisiana. And that's the same thing that we see really in almost every health measure that I have in my state. But there's a tension right now on COVID-19, and I can leverage that bully pulpit to talk about the impacts of health disparities on broader health within communities of color in the state, but also specifically on hepatitis C and the issues of equity and the deadliness of inequity.
Thank you, Alex. Boatemaa, what would you like to add to that?
I think that was just stated and framed absolutely. It was perfect. I think that right now the need to eliminate viral hepatitis is more compelling than ever. We have vaccines to prevent viral hepatitis, which means fewer immunocompromised people who are at higher risk when it comes to COVID. We have an opportunity to cure hepatitis C, which also reduces the number of people who are at higher risk for COVID-19. And then, as both Alex and Lauren have spoken to, is just this opportunity for innovation. I really appreciate that Alex said, when people are getting tested for COVID, why wouldn't we just add on additional testing, especially if we can do it in a way that's not too invasive for the individual? We have a number of people who are accessing the healthcare system for the first time in months or years. And this is really an opportunity to engage folks and make sure that they are up to date on their vaccinations and that they have access to them, to make sure that they do know that testing is available more broadly, and that while it is significant and important that people know their status as it relates to COVID-19, that they also are looking at a more comprehensive look at their care overall, viral hepatitis very much being a part of that. So as we strengthen our public health infrastructure, this is very much a part of that.
So Lauren, I'm going to ask you to respond also, but I'd like to kind of throw in another dimension. I know you are, and some of our audience may be aware of the fact that the Centers for Disease Control and Prevention is poised to award $10.25 billion to state and local health departments to expand the epidemiology, surveillance, and laboratory capacity to get ahead of the COVID-19 pandemic. Knowing that surveillance for viral hepatitis in the United States is so underfunded, I wonder if, in addition to your other thoughts about how we keep viral hepatitis elimination efforts going, if you can talk about what are some of the advocacy or communication strategies that we can reach policymakers to try to maybe use some of these resources to improve surveillance activities for viral hepatitis?
Absolutely. This has been a really interesting topic of discussion in our meetings on the Hill. Lawmakers are really interested in what we've learned from viral hepatitis. Not really knowing the size of our epidemic is difficult. Surveillance is the cornerstone of public health. We can't do anything else without surveillance. And as we've seen, it really helps us direct our efforts as we're seeing disparities in who's getting tested and treated. It helps us understand the scope of our problem. So I think we're seeing a good amount of investment in surveillance right now. And my hope that will benefit our viral hepatitis programs. In particular, I think development of sort of electronic laboratory reporting so that folks aren't entering manual forms to report cases, supporting contact tracing, which hopefully is staff that can be retained, because I know our healthcare system is pretty under-resourced as it comes to investigating hepatitis A, B, and C through contact tracing. And then, of course, development of systems that are interoperable. So, Massachusetts is a great example. They have this incredible surveillance system that links across different hospital centers, different clinical centers. It's pretty advanced, but it's expensive. A lot of other states just don't have the capacity to create such a system, and it creates a lot of informatics challenges and resources are needed. So my hope is that some of this funding really will help that infrastructure. But to answer your original question, in terms of advocacy, we're really trying to highlight the intersection of COVID-19 and those with chronic liver disease. Our hope is that we can encourage CDC to direct some of that funding, at least, to those patient populations that have underlying conditions. Whether it's liver disease, heart disease, asthma, those populations need concerted messaging. in the case of viral hepatitis, they need to know that they're walking around with a condition that could put them at greater risk in the immediate term of COVID-19. So that's been one of our biggest messages in advocacy. And just this last week, in terms of treatment access, I was at DC Medicaid, talking about how we need to make sure people are getting treated for hepatitis C, because they are walking around with this condition that shouldn't be there, could be complicating COVID-19.
Thank you. I'm going to go to a very specific question that was asked. Alex, this is for you. And this is along the lines of accommodations that are being made in clinical care as a result of COVID-19. And this audience member wondered if Louisiana had considered using dried blood spots as a way to verify a sustained viral response. So, I mean, it's a very specific question, but it was asked. So can you provide some information for us, please?
Yeah, and I hinted at this just at the little bit at the end of my talk, and can give much longer talks about how we really see the opportunity for elimination as an opportunity to rethink hepatitis C care in general. But I think that if there is an upside to COVID, it has forced the issue for maybe some of the people who had a lot of concerns about the kind of flexibilities we wanted to drive in the system to allow us to reach more people. The approach that we've taken in Louisiana is really, saying if we've got an extremely effective, essentially pangenotypic, panfibrotic cure that treats, 95, 98% people, let's start removing barriers and just getting pills into people's mouths, and then thinking later about how we do testing and how we do fiber scans and how we do all this additive care in parallel, not in serial as we've traditionally sort of stacked these fences in between us and treatment. And so I think the same is true now with COVID-19. We've broken through a lot, at least in Louisiana, a lot of telemedicine barriers, a lot of flexibility barriers, as this question asks around, testing. We stood up in Louisiana, a testing action collaborative, because as a state, I knew that we weren't going to be able to do everything we need to do for COVID-19 through the state lab alone, or through letting our partners figure out their own path. We very early on have been having weekly calls with all of our state labs, research, private, state and academic, coordinating our COVID-19 activities, and not just in PCR testing, but in what viral or what serology studies are we going to use. That infrastructure, that muscle memory that we're developing through weekly conversations, we can now go back to over and over again as we tackle these other issues. So it's not just going to be as the state lab willing to address dry blood spots for hepatitis C, we can ask that now of all the labs we're connected to and come up with a coordinated answer. So I think we have to see this as an opportunity to leverage the connections that we're having to make out of desperation for opportunity going forward. Don't let it fall away.
So I'm going to ask all three panelists to respond to this one. The issues related to the intersection of the COVID-19 pandemic, viral hepatitis, this would apply both to C and B, and correctional health. And I know that's obviously an issue in Louisiana because correctional health was one of your initial targets for elimination. But I'd like to hear from all three of the panelists about your thoughts about, just general thoughts about the intersection of those epidemics, and not just the challenges they present, but are there opportunities here to, so for instance, Boatemaa, social justice is part of the underpinning of NASTAD, and criminal justice reform. I mean, all of this is interrelated, but what thoughts do you have about that? And let me start this time with Boatemaa, if you can share any thoughts about that.
So I'll say admittedly, Ron, in terms of the COVID-19 pandemic, there is me, Boatemaa personally, and there's me, Boatemaa, within the context of my work at NASTAD.
Okay. Well, we'll take it from both of you.
All right. So I'll say within the context of my work at NASTAD, I know that this is something that's at the forefront of our viral hepatitis program's minds, especially because one of the first things that we heard from programs was with the onset of the pandemic, correctional settings had essentially said, we're ceasing some of the work that we had been doing, where you were helping to conduct testing, especially in jails. What we haven't really gotten a lot of information about is what the actual change in testing and treatment, what changes, if any, related to testing and treatment for hepatitis B and C have actually happened within the correctional setting. So I don't actually have that information available. But what I do know is that advocacy continues as we look at ways that we can protect our sisters and brothers that are systems involved from being exposed to COVID-19 and not having the resources necessary to be able to address the COVID-19 pandemic within correctional settings, that there's also an opportunity for a much larger conversation about infectious disease within correctional settings, what we do to control them, what resources are made available, and how we ensure that the systems that we set up now in response to COVID-19 or the barriers and the missteps that might exist currently that have resulted in a number of people being released early, that we really take that and use it as historical knowledge that informs our response to infectious disease in correctional settings going forward.
Yeah, I guess before we go to Lauren, I guess another way of looking at this, and all three of you have mentioned this, is that the COVID-19 pandemic has continued to underscore the shortcomings of looking at diseases categorically. We're going to do a great job setting up this social system, a social net to deal with people that don't have insurance who can be treated for HIV. What about other infectious diseases? So, I mean, one hopes that, especially in publicly funded systems, that we're going to end up seeing a more integrated approach. But Lauren, what are your thoughts about correctional health and Hep C, Hep B, and Hep A?
Yeah, you're right. I mean, none of these exist in a vacuum, right? And I'm grateful that we have leadership in Louisiana, for example, with Alex and other states where health officials appreciate incarceration as an opportunity for public health intervention and really prioritize that. I think we need more support on the federal level, though. I think states, most people are incarcerated in state prisons or county jails, and that means the budget for healthcare comes from state and local budgets, and they're just too small, and it's really disparate across state lines. So given that people who are incarcerated have a constitutional right to healthcare under the 8th Amendment, I think we need more support from the federal government to ensure that there is standard healthcare provision in any correctional setting. And as such, I was delighted to see that in the HEROES Act, which is for the next phase of a COVID stimulus bill that was approved by the House, there was a significant investment in health services support for correctional facilities. There was a call for decarceration of people over the age of 60 or those with underlying health conditions. And there was a call for the extension of Medicare and Medicaid coverage before release that might help folks kind of get taken care of at least before they're let out. So I think we're having a national conversation around this, and I would like us to ensure that we really capitalize on that and drive change, because we can't keep up the status quo. And people just haven't been getting good enough quality care.
Thank you. Alex, any any thoughts at all, whether they're Louisiana specific or broader?
Yeah, maybe, a plus side and a downside. So I think the plus side is, the work that we had been doing for hepatitis C elimination, partnering with the Department of Corrections for, over a year, actually put us in a pretty good position to really act early for COVID-19. We had, the CMO of the corrections agency or Department of Corrections and myself know each other well. We live not too far from each other. Reached out to him as soon as we were starting to develop guidance. What are your plans? What are you talking about with the jails? How are you guys building up your plans? So we were able to build on that connection, of knowing each other's processes. I knew the distribution of Louisiana's a state inmate population, which is half within state facilities, half within local facilities, to understand the challenges we were about to face. So that was really helpful to already have that experience. But I think the downside, and to echo what Lauren's saying, I mean, I'm calling you from the incarceration capital of the world. And I think that as we've been talking about the risk that incarceration presents for these individuals for COVID-19, I think if there's anything productive about that, well, there's a lot productive about that, but I think it really has given us, from a public health standpoint, the opportunity to rediscuss our incarceration policies that predominantly, disproportionately, and unfairly impact communities of color, not just in this state, but certainly in this state. And I think it gives us the opportunity to really introduce ourselves in that conversation, because they're looking to us for help in understanding how to keep their staff safe, keep correctional staff safe, and keep inmate populations from having higher rates of death. This is our way to insert ourselves into deeper discussions of inmate health, of the justice system, and how we can think about ways of addressing public safety without the risk of public health.
Thank you, Alex. There is a third question, Lauren, directed to you that focuses on issues related to ongoing investment in hepatitis C vaccine development. I mean, the question is phrased, should we continue to invest? I know your answer will be yes, but I guess, again, putting a little twist on that, how do we, there's going to be a lot of competition for resources in the upcoming years, but is Hep C, is the development of a vaccine for hepatitis C part of the advocacy portfolio for NVHR? Can you just speak to that briefly?
Mm-hmm. Absolutely. In fact, there's been a lot of public comment opportunities this month, and one of them was for the strategic plan for NIDDK, which is within the NIH, to call for research around hepatitis C vaccine development. There's a lot of folks working hard on developing COVID vaccines, and we put our mind to it and resource the research. We can make great progress. We certainly want to see that, and that's a priority. For me right now, my priority around vaccination really is ensuring that we are using the vaccines we have. We have a hepatitis B vaccine, and less than 25% of adults are vaccinated. We're seeing increases among people that use drugs, increases in Appalachian region in particular. So, vaccine is only good if you can get it to the folks who need it. So we're doing what we can to try to encourage uptake and to promote hepatitis A vaccination widely, given the outbreaks. I mean, 60% of those who've been infected with Hep A in these widespread outbreaks have had to be hospitalized. We've had hundreds of preventable deaths, and we need to be getting that vaccine out there as well. It's been really promising to see the interest of lawmakers in learning from our hepatitis A vaccine efforts as they're thinking about COVID vaccine dissemination when it's developed. There's a lot that we can learn from our colleagues that have worked in viral hepatitis on the ground about reaching underserved communities and making sure they're vaccinated. And I think they're going to be crucial in ensuring that our COVID vaccine is successful.
Okay, amen, sister. We're almost out of time. I'm going to give each of you a very quick opportunity, not for a speech, but for a parting shot to our audience about how we keep our hepatitis prevention, control, elimination programs alive and healthy. Quick thoughts, Alex.
Public health and public health leadership at the local, state, and national level has never been more visible and trusted in poll after poll. We cannot let that opportunity slip. We need to talk about how to address comprehensive issues like hepatitis and others.
Great. Boatemaa?
Viral hepatitis program staff at health departments really are at the core of the public health response to COVID-19. I think this is an opportunity to utilize that expertise not only to respond to COVID-19, but to also look at how we integrate their knowledge, their expertise, and viral hepatitis work across areas, including when we're looking at that $10 billion, looking at how vaccination, screening, and linkage to care can be integrated into activities. And I also just want to say that I think that we're in this really important time to recognize that we have to approach our work with a health equity lens at the forefront, looking at the disproportionate impact that these things are having on Black and Brown communities as well as other communities.
Okay, and Laura.
Parting shot is just that, agree with everything that Alex and Boatemaa have said. In addition, I think as we're thinking through how to drive elimination, as we're thinking through what our program should look like in this new context, we have to continue engaging with people with lived experience of viral hepatitis and with COVID, especially from those communities that are disproportionately impacted. I think we have a tendency to say, okay, there's a problem, let's fix it, without doing that work of really elevating those voices. So I think in any decisions we're making and any funding that we put out, any policies we're making and discussions with lawmakers, we need to make sure that there's a seat at the table for people with lived experience so that we can make sure our programs are effective and really getting to those who need it.
Great. Well, I want to conclude by thanking all three of you for doing an outstanding job. Obviously, we could go on for another hour talking about this issue. I would encourage all of the audience members to not only check out the HepVu website, but check out the resources that NASTAD and NVHR have available on their websites. And again, I'll remind you that this presentation and the slides will be publicly available at the HepVu site, probably no later than tomorrow. So thank you all. You guys did a great job. I appreciate you taking the time out to share this important information with us. And thanks to HepVu for hosting this webinar. So having said that, I'll say keep on working and stay safe.
Thank you.
Bye-bye. That concludes our webinar. And don't forget to tune in for the webinar on the 11th on harm reduction.